Welcome to the Deep Dive, your shortcut to being genuinely well-informed. Today, we're plunging into something really fundamental, the core principles of patient care.
That's right.
We've gone through a pretty comprehensive foundation study guide, and honestly, this isn't just for doctors or nurses.
No, not at all.
Our mission is to pull out those key nuggets, the essentials, so you can understand what really underpins, effective, compassionate, and safe interactions in healthcare. It's about seeing beyond the tasks to the art and science involved.
Exactly. And what really jumps out from this guide is that these aren't just dry rules from a textbook.
Right.
They're living, breathing frameworks. They guide every single interaction. They ensure safety, promote actual healing, and forge that vital human connection. It turns healthcare into something truly holistic.
Okay, so let's start with maybe the most basic building block, but one that's surprisingly complex in healthcare, therapeutic communication. It's more than just chatting, right? What's the specific purpose here?
Well, it's completely purposeful. It's focused entirely on the patient, their needs, their feelings, their well-being. The goal isn't just small talk.
Okay.
It's about gathering really crucial information, helping patients cope with what they're going through, supporting their decisions, providing education, and maybe most importantly, building that foundation of trust.
So it requires a certain mindset then.
Absolutely. You have to be patient-centered, non-judgmental, deeply empathetic, honest, respectful, and always maintain those professional boundaries. Plus being aware of your own biases, which is key.
Right, self-awareness. So how do you actually do that? What are some of the techniques that make a real difference beyond just listening? I think I saw something called SOLAR.
Yeah. Active listening, where you actually reflect back and paraphrase. That's fundamental.
Got it.
Then there's using open-ended questions. Think, tell me more about what that pain feels like.
Yeah.
Instead of a closed question like, is your pain better? Which just gets a yes, no.
Ah,
And yes, SOLAR. It's simple, but really effective for nonverbal communication. S is sit squarely, facing the patient. O is open posture, no crossed arms. L, lean forward just slightly, shows engagement.
right.
E is eye contact. But, and this is important, always consider what's culturally appropriate.
Good point.
And R is just relaxed.
Yeah.
It conveys presence and openness. And don't underestimate the power of silence sometimes.
Oh, how so?
Well, giving the patient space to think, to process, you don't always have to fill the silence. And using empathy statements like, that sounds really frightening, I'm here with you, can be incredibly powerful.
That makes sense. Not jumping in immediately. Okay, so on the flip side, what are the things to definitely avoid? The communication pitfalls.
Oh, there are quite a few. A big one is false reassurance.
yeah.
Saying, don't worry, you'll be fine. You can't promise that.
Right, you can't.
Also, giving advice they didn't ask for, minimizing how they feel,
Correct.
suddenly changing the subject if it gets uncomfortable, or moralizing
Yeah, that sounds unhelpful.
and asking why. Questions can often sound accusatory, making patients defensive. These things just break down trust. Instead, you can use things like motivational interviewing, which really helps patients find their own reasons for change. And in a crisis, well, communication shifts. It needs to be calm, super clear, short instructions for immediate safety.
And capturing all this accurately must be vital.
Absolutely critical. When you document, always use direct quotes for what the patient says their subjective experience. It keeps their voice accurate.
Okay, that flows nicely into the next part, from the words we use to the context of the person we're speaking with. Cultural competence. How do we define culture here? And why is competence seen as this ongoing journey?
So culture is basically the learned beliefs, values, behaviors. The stuff that shapes how people see the world, how they experience illness. And competence isn't like a checkbox you tick off. It's a continuous process. It starts with just being aware of differences, the gaining knowledge, then developing skills, and actually applying them respectfully in every encounter. It's really about being curious, not making assumptions.
So it's less about becoming an expert on every single culture, which is impossible anyway,
Exactly.
and more about having a framework to approach anyone with respect. What does that look like practically?
It looks like asking open-ended questions, asking about their preferences, maybe for providers' gender or dietary needs during illness, or even traditional healing practices they might use.
Okay.
And a really critical point, for anything complex, always use certified medical interpreters.
Not family members.
Preferably not,
Yeah.
especially for sensitive things.
Ugh.
Family might misunderstand or edit, or it could breach privacy. Certified interpreters are trained for accuracy and neutrality.
That's a crucial distinction. What else?
Tailoring how you teach. Maybe using visual aids or metaphors that resonate, or materials in their own language. The main thing is, avoid stereotyping. Reflect on your own assumptions and just ask the individual what matters to them.
Makes sense. And for documentation.
Note down their language needs. Definitely note if an interpreter was used, and any specific cultural or religious preferences that are relevant to their care plan.
Okay, let's delve into spirituality and religion now. These are obviously deeply personal areas. How do healthcare teams even begin to assess these needs sensitively?
Yeah, it's delicate, and it's good to distinguish the two. Spirituality is often broader, that search for meaning, purpose, connection. It might not involve organized religion at all.
Right.
Religious beliefs are usually tied to specific practices, traditions, a faith community. To assess, there are tools like FICA.
FICA.
Yeah, it stands for faith beliefs, importance, community, and how they want these addressed in their care. Or HOPE, sources of hope, organized religion, personal practices, and effects on care. They just provide a gentle structure for the conversation.
So what's the caregiver's role then? How do you support these needs without, crossing lines?
The role is really to assess, support, and facilitate. Understand what gives them hope or comfort. Offer to call a chaplain or their faith leader if they want. Accommodate practical things like diet, fasting, modesty needs.
Okay.
The absolute boundary, ethically, is never to proselytize or impose your own beliefs. It's about respecting and supporting their spiritual path.
And documenting this appropriately.
Yes, definitely.
Yes.
Note the spiritual assessment. Any interventions, maybe they requested prayer or a chaplain visited, and how the patient responded. It's part of seeing the whole person.
All right, let's shift gears to something absolutely critical: patient safety and risk reduction. Preventing harm, physical harm, medication errors, infections, falls. The list goes on.
It's paramount.
And this isn't just about individuals being careful, is it? There's this idea of systems thinking.
Exactly. What's crucial to understand is that errors rarely happen because just one person messed up. They're usually system-based, meaning you look at the whole process, the environment, the equipment, the staffing, the communication, the training, to find where the weak spots are. It's about designing safer systems, preventing errors before they happen, not just pointing fingers after.
Okay, so what are some of those really high-impact, basic safety practices, things maybe even patients and families should be aware of?
Great question. Number one, patient identification. Critically important. Always use two identifiers, usually name and date of birth, right from their wristband.
Not the room number.
Never the room number alone. Ask the patient to state their name, too, if possible. Second, medication safety. This means the 6 rights: right patient, right drug, right dose, right route, right time, and right documentation.
6 rights. Got it.
And for high alert meds, things like insulin, heparin, opioids often requires a double check with another nurse.
Makes sense. What else?
Third, infection prevention. Seems basic, but meticulous hand hygiene. Using personal protective equipment, PPE correctly, and maintaining aseptic technique are vital. And finally, falls. It's about assessing risk, clearing hazards, keeping the bed low and locked, call light within reach, non-skid socks, all those preventative measures.
But even with all that, things can still go wrong. What happens then? What about reporting, and what's a sentinel event?
Reporting is key, even near misses. That's how systems learn. A sentinel event is a really serious adverse event, something that causes death or severe harm, like operating in the wrong limb.
Oh, wow.
These automatically trigger a deep investigation called a root cause analysis, or RCA. The goal isn't to blame, but to figure out why the system allowed it to happen and fix those underlying issues. It really underscores why patients and families speaking up if something feels wrong is so important. They're part of that safety net.
That's a really powerful perspective. Okay, another key area for safety and efficiency: delegation. This is where an RN assigns a task, but crucially, keeps the accountability. Isn't there a handy acronym for the things an RN absolutely cannot delegate?
Yes, a very useful one. Think of what an RN must always eat. Evaluate, assess, and teach.
EAT.
These core nursing functions require clinical judgment. So the initial assessment of a new patient, the first time teaching about a new diagnosis or medication, or evaluating how a patient responded to an intervention, those cannot be delegated. They stay with the RN.
That's crystal clear. And for the things that can be delegated, there are the 5 rights to make sure it's done safely.
Yes, the 5 rights of delegation. It's a checklist, really, to ensure it's appropriate. Is it the right task? Is it the right circumstance? Is the patient stable enough? Is it the right person? Do they have the skills and training? Did I give right direction and communication, clear instructions? And will I provide the right supervision and evaluation?
So it's a whole thought process.
It is. It's risk management, not just handing off a job.
Can you give us a quick rundown of who generally does what, like RNs, LPNs, UAPs?
Sure, general guidelines. RNs handle the complex stuff. Comprehensive assessments, initial teaching, unstable patients, creating the care plan, and supervising the delegation itself.
Okay.
LPNs, or LVNs, licensed practical vocational nurses, typically care for stable patients, administer many medications according to policy, handle routine wound care.
Right.
And UAPs, unlicensed assistive personnel, help with activities of daily living, ADLs, like bathing, feeding, ambulating, taking vital signs on stable patients, positioning. A common pitfall is assigning something that needs nursing judgment, like assessing pain, to a UAP, or just not following up to see how the task went.
And of course, document everything.
Always document the task delegated, who did it, and crucially, the patient's outcome related to that task.
Okay, now for what you called the backbone of nursing care, the nursing process, ADPI.
ADPI.
Yes. You said this is how nurses structure pretty much all their care, a systematic problem-solving method. Can you unpack those letters for us?
Absolutely. ADPIE gives you a clear roadmap. A is for assessment. First step, gather all the info. Subjective, what the patient tells you. Objective, what you observe or measure, like vital signs, lab results, physical findings.
Okay, gather data.
D is for diagnosis. This isn't the medical diagnosis like diabetes. It's a nursing diagnosis, the patient's response to their health issue, like risk for unstable blood glucose or impaired gas exchange. Uses a specific format.
Patient response, got it.
P is for planning. Here, you prioritize what's most urgent. Airway, breathing, circulation, the ABCs always come first. Maslow's hierarchy helps two basic physiological needs first. Then you set SMART goals.
Smart.
Specific, measurable, achievable, relevant, and time frame, like patient will walk 50 feet with assistance by tomorrow afternoon.
Clear goals, okay.
I have for implementation. This is doing the plan. The interventions could be giving meds, teaching, performing a procedure, collaborating with other team members.
Taking action.
E is for evaluation. Finally, you check it. Did the interventions work? Did the patient meet the goal? How did they respond? Based on this, you might continue the plan, modify it, or determine the problem is resolved. It's a cycle, constantly reassessing.
That's a really robust framework. Let's try a quick example. Say a 68-year-old comes in short of breath, O2 sat is low at 88%, you hear crackles in their lungs, history of heart failure, CHF. How does ADPI work right then?
Okay, good example. It happens fast in real time. Assessment, you grab that data, shortness of breath, RR28, O2, SAT 88%, crackles, CHF history.
Right.
That's your assessment.
Right.
Diagnosis. Nursing diagnosis might be impaired gas exchange related to alveolar fluid accumulation as evidenced by O2, SAT 88%, and dyspnea.
Okay, connects the problem and cause.
Plan and goal. A SMART goal. Patient's O2 SAT will increase to at least 94% on 2 liters nasal cannula within 1 hour. Prioritize this over, say,
Great urgent need.
Implementation. Immediately. Raise the head of the bed, apply oxygen, start monitoring vital signs closely, maybe every 15 minutes, and get ready to call the provider if there's no improvement.
Okay, the action.
Evaluation. After maybe 30, 60 minutes, recheck that O2 SAT, reassess their breathing. Did they meet the goal? If yeah, great, continue monitoring. If no, you need to escalate maybe more oxygen, call the doctor urgently. It ensures nothing gets missed in the heat of the moment.
That really shows the process in action. Quick decisions, but structured.
And the rule of thumb for prioritizing is always life threats first. Airway, breathing, circulation. Acute problems before chronic ones. Actual problems before potential risks.
Excellent point. Okay, speaking of precision, let's touch on dosage calculations and medication safety. Getting that dose exactly right seems, well, terrifyingly important.
It is absolutely non-negotiable. Precision is everything. And a small decimal point error can have huge consequences. We use basic formulas like desired dose divided by the dose you have on hand times the quantity or volume.
Simple formula, high stakes.
Exactly. And knowing basic conversions is key. Like 1 gram is 1,000 milligrams, 1 kilogram is 2.2 pounds. But beyond the math, it's about safe practices.
Like what? I think I read something about leading zeros.
Yes. Crucial. If a dose is less than 1, like half a milligram, you always write a 0 before the decimal, 1.5 milligrams.
Okay.
But you never use a trailing 0 after a whole number. Don't write 5.0 grams, just write 5 milligrams. That trailing 0 can easily be misread as 50 milligrams if the decimal isn't clear.
Ah, I see. Simple rule, big impact.
Huge impact. And another layer of safety, especially for high-risk drugs, is having a second nurse independently double-check your calculation before you give the medication.
Makes sense. Like that digoxin example, 0.25 milligram ordered. You have 0.125 milligram tablets. Quick math, 2 tablets.
Precisely. Or calculating an IV drip rate, say 1 gram and 250 milligrams over 30 minutes means the pump needs to be set at 500 millirels per hour. Accuracy prevents harm.
Okay, we've talked a lot about the nurse-patient interaction, but healthcare is definitely a team sport. Let's zoom out to the interprofessional team. Who are the typical players involved here?
Oh, it's a whole cast of characters, all crucial. You've got the RNs, LPNs, LVNs, nurse practitioners, NPs, physicians, MDSDOs, physician assistants, PAs, pharmacists, physical therapists, PTs, occupational therapists, OTs, speech therapists, SLPs, social workers, chaplains. The list goes on.
Wow, yeah, a lot of expertise. How do they all stay coordinated, especially during shift changes or when a nurse needs to update a doctor quickly?
Communication is key, and standardized tools help immensely. One of the most common is SBAR.
SBAR.
Yep. Situation, background assessment, and recommendation. It's a structured way to pass on critical information clearly and concisely. Here's the situation, here's the relevant background, here's my assessment, here's what I recommend or what I need. It cuts down on errors and ensures everyone's on the same page fast.
That sounds incredibly useful.
Okay.
Okay, let's talk about the professional compass. The American Nurses Association, the ANA, they set the ethical code and standards.
They do. The ANA Code of Ethics is foundational. It outlines core principles like compassionate and respectful care, advocating for patient rights and autonomy, maintaining competence, ensuring confidentiality, and fulfilling broader professional and social obligations.
And the standards of practice.
Those provide the benchmarks for quality. They guide everything from how nurses perform assessments to diagnosis, planning, implementation, evaluation, ethics, cultural competence. It defines the expected level of professional performance. It's the how-to of professional nursing.
Got it. Now, something vital for everyone, HIPAA and confidentiality, protecting patient information. What exactly is protected health information, PHI, and what are the absolute must-know rules?
PHI is basically any information that can be used to identify a patient. Name, birth date, address, phone number, social security number, medical record number, diagnosis, treatment, photos, even billing info.
So pretty much everything.
Pretty much. The core rules are simple but strict. Share PHI only with those who have a legitimate need to know for the patient's treatment, payment, or healthcare operations. This is the minimum necessary rule.
Minimum necessary. Okay.
You generally need patient authorization to share it for other reasons, and you must use secure methods, encrypted email, secure patient portals, absolutely no posting about patients on social media, even vaguely.
What are common mistakes people make?
Discussing patients in elevators or cafeterias, leaving charts or computer screens visible, even just talking too loudly at the nursing station. It requires constant vigilance.
Definitely. Okay, a sensitive but necessary topic. Restraints. Physical ones, chemical ones, seclusion. What's the guiding principle here?
The absolute guiding principle is use the least restrictive option necessary for safety and only as a last resort.
Last resort only.
Yes. They're only used to prevent immediate harm to the patient or others, and only after you've tried and documented all other less restrictive alternatives, like de-escalation, redirection, having a sitter. It's a serious infringement on autonomy.
So what safeguards are required?
Strict ones. You need a provider's order. It must be time limited and based on specific criteria, not just for convenience. You have to document why it was needed, what alternatives were tried, and then monitor the patient, constantly checking circulation, skin, basic needs, readiness for removal. The goal is always to get them off as soon as it's safe.
Understood. Let's make sure we touch on inclusive care, specifically around gender and sexuality. How do we ensure care is truly respectful and patient-centered for everyone?
This is fundamental to good care. It means things like consistently using a patient's chosen name and pronouns. If you don't know, ask respectfully.
Just asked.
Yeah. It means focusing your questions on anatomy and behaviors relevant to their health, not making assumptions based on their gender identity or appearance. It means providing confidential, completely non-judgmental sexual health assessments and information.
Are there frameworks for that?
There are. The Plicit model is one. It guides conversations from just giving permission to talk about sexuality to providing limited information, then specific suggestions, and knowing when to refer for intensive therapy if needed. It's all about creating a safe, affirming space for every single person.
That's incredibly important. Okay, let's wrap up our main content with a look towards wellness, health promotion, and disease prevention. This is about guiding people towards better health long-term.
Exactly. It moves beyond just treating illness. There are three main levels of prevention we talk about.
3 levels.
Yeah. Primary prevention is about stopping disease before it even starts. Think vaccinations, education on healthy eating, smoking cessation campaigns.
Preventing the initial problem. Okay.
Secondary prevention is about catching diseases early when they're easier to treat. This includes screenings like mammograms, colonoscopies, regular blood pressure checks.
Early detection.
And tertiary prevention is for people who already have a disease. The goal here is to limit the disease's impact, prevent complications, and improve quality of life. Think cardiac rehab after a heart attack or managing diabetes to prevent kidney damage.
Managing existing conditions. Got it. So how do healthcare providers actually help people make healthy changes? And what are the best ways to make sure patient education actually sticks?
Well, first, you have to see if the patient is even ready to change. You can't force someone. Assessing their readiness helps tailor the approach. For education, a fantastic technique is teach back.
Teach back.
You ask the patient to explain the information back to you in their own words. It immediately shows you if they understood it correctly or if you need to explain differently.
Simple but effective.
Very. Also, use plain language. Avoid jargon. Use culturally appropriate materials. Break things down into small, manageable steps. And always consider the social determinants of health. Things like a person's income, education level, access to healthy food, safe housing. These factors outside the clinic walls have a massive impact on their health and ability to follow recommendations. You have to see the bigger picture.
Wow. This deep dive really highlights the incredible range of knowledge and skill that goes into foundational patient care. It's not just tasks. It's communication, ethics, safety systems, complex problem-solving, teamwork. It truly is a blend of head and heart.
It absolutely is.
Mm.
And maybe the final thought here is that these principles, they might seem straightforward on the surface, but mastering them requires constant learning, constant adaptation, and this deep, unwavering commitment to the individual human being right there in front of you.
A continuous process.
Definitely. So perhaps think about how your own understanding of what care really means has shifted, even just from this conversation. And consider how these core ideas will keep evolving with technology and society, but hopefully always, always stay centered on that fundamental human experience.